So good afternoon. So this instruction course will be on the different projects that we have conducted here in Arvind Eye Care System as a whole. And we have with us very eminent speakers, myself, Dr. Meenakshi Ravindran, who is the Chief of Pediatric Ophthalmology from Tirunelveli. We have Kalpana ma'am, who is Chief from Arvind Eye Hospital, Coimbatore. Dr. Anjali, who is a Medical Officer from Pondicherry, and Dr. Sahitya Bhaskaran, consultant from Arvind Eye Hospital, Madurai. So let me begin this session, and I'll be talking on a project. These are all USAID based projects, and this particular project was carried out in the year 2014 to 16, which is on the screening, treatment and rehabilitation of children with low vision. Slides? I can see it here. The slide is not moving from this. Yeah. So talking about the magnitude of low vision, so the magnitude is quite big, with around 285 million vision impaired and 39 million blind people, and most of these blind and visually impaired live in the developing countries. So as we can see from this graph here, most of the developing countries, including India and China, have the maximum number of people with vision impairment, and this statistics is from the global impairment by WHO. And also, when we see the causes for blindness as a percentage of the global blindness, the cataract is the maximum, both in total blind and vision impairment, followed by refractive errors and many other causes, including corneal, ROP, and retinal, including age-related macular degenerations. So coming to the present scenario in India, the prevalence of the functional low vision is about 2.5 per thousand population. But the problems are lack of awareness and professional assessment, lack of early intervention, and we do not have comprehensive low vision care in many places. Access is poor and stigma to use devices. So the barriers to low vision care in India being, it has always remained a low priority. There are very few centers specializing in low vision care, with poor access to services, poverty, illiteracy, and social stigma. Many people do not like to use these devices in public. Lack of awareness and lack of affordability, and also children with low vision are studying in blind school. Aging and increased longevity is also will increase the population of people with low vision. So we need to have the scope of services at the primary level. We need a lot of around 2000 centers for the current prevalence, and secondary around 400, and tertiary at least 100. And the primary level being mainly manned with the primary health workers, community health based rehab workers, and teachers. So at the primary level, they can liaise with the MLOPs, where they can do a basic refraction and low vision assessment, and they can dispense simple devices. And we need to work at the grassroots level with the school teachers, special educators, social workers, and volunteers. And at the secondary level, we have community centers and regional hospitals, where you can man it with ophthalmologist and optometrist and rehab health workers and volunteers. And there again, you can have some degree of linkage with the educational outreach services also. And here at secondary level, again, we can do refraction, prescription of devices, diagnosis, assessment, and vision training, and a few complex cases can be referred to the tertiary care centers. So at the tertiary level, again, we have the ophthalmologist with optometrist and rehabilitationist, because rehabilitationist is very important at the tertiary level, so that they can do a proper functional vision assessment, train to use the low vision devices, orientation, mobility guidance, and educational vocational guidance, and rehab counseling. So with these in mind, because we were not targeting the grassroots level, most of our treatment was only for patients who are reaching the base hospital. So we plan to do a community based service for children with low vision in the area of Coimbatore. And the objectives is to enable early identification of children with low vision in community and refer to base hospital, subsidizing the cost of low vision devices for people who cannot afford to buy them, upgrade the existing low vision clinics, and increase the capacity to provide better services and expand coverage in the surrounding districts. And so we had included the vision technicians at our vision centers, field workers, key informant strategy, SSA teachers who formed a major bulk of our project by identifying these children, school teachers, Anganwadi workers, primary healthcare staff, and blind school surveys. So these are the pamphlets we had made, and we had given a training to the field workers and the vision center technicians. Key informant interview from a variety of people, including like panchayat presidents, Anganwadi workers, PHC staff, village health nurses, PHC refractionist, and community residents. And the teachers training program was done with the help of SSA teachers. So the number of teachers who participated from the districts was quite promising. In Coimbatore we had around 98, Tripur around 22, Erode 70, and Salem was around 89. And these were the details of the camps that we conducted, and we could identify a lot of children in this way. So these are the photos taken by the school teachers who had shared with us during the time of the project, where it is seen that the children did not have much stigma to use the devices in their classrooms. So this is the Anganwadi screening by the field workers, and we had done camps in even far-flung areas as a part of this project, including camps for the tribal population in remote areas, and special schools and non-governmental organizations also were screened, where we found a lot of children with multiple disabilities also having low vision, like children with autism and cerebral palsy, who are being identified and given appropriate services. And this was the camps in the special school for the blind, where we could identify a few children, and also few children who are having cataract, who are operated as part of the project. So this is the screening details. In the end, we can see that the field workers and SSA teachers had contributed to the maximum number of children screened and identified, and out of which the refractive error, whoever needed glasses, were corrected. Surgeries were also done as part of this project free of cost. So we had screened around 8 lakhs children and identified around 1,600 kids with low vision, and we had given the respective interventions, including glasses, devices, and surgeries were also done, and a few of them for early intervention training. So the expected outcome was to enhance the system and processes for identification of low vision cases. So even after the project ended, we still have touch with all these people who even now refer cases to us, and capacity building of organization to provide a comprehensive low vision service and rehabilitation services. Thank you very much. So I would...
Dr. Kalpana, not Meenakshi, Dr. Kalpana. Yes, thank you. Come. Okay. Thank you, Sandra, for giving an opportunity to be part of your IC. So this is about the childhood cataract project, which was supported by the US side. We're going to talk about the experience of this project we just recently concluded. So this project, the title of this project was A Step Further in Childhood Cataract. The focus was to eliminate childhood blindness due to cataract in southern India. And we focused on screening, evaluation, management, rehabilitation, and training. The duration was August 21 to April 2023, 21 months. The target was to screen 650,000 children and do 4,000 cataract surgeries, pediatric cataract surgery, and to train 1,380 pediatric healthcare providers and teachers. So the main objective was this project was to create awareness in the community, also in the medical fraternity, that there is such a thing called a pediatric cataract, and early intervention is very important. So timely diagnosis and referral is important. and this is what the main objective. So to do this, to strengthen the training among pediatricians, neonatal intensive care units, ophthalmologists, residents in ophthalmology and pediatrics, healthcare workers, optometrists, school teachers. This is mainly to diagnose the problem at a very earlier stage, and also to evaluate, provide prompt management, rehabilitation of these affected children. So we focused on, one is training, the other one is awareness. The training was mainly given to healthcare providers, educational institutes, and also other NGOs who are closely working with us. And the awareness was also done to healthcare providers like PHC workers, Anganwadi workers, and in the general community when we go for outreach programs, and NGOs about the project and the goal of the project. So this training in healthcare providers, there's a lot of awareness, lack of awareness in the medical personnel regarding the importance of early intervention. So we did this KAP study, the Knowledge, Attitude and Practices Survey, which showed that only 30% of the pediatrician or physician felt that the child is too small. They thought it was too small to undergo surgery. So we really have to, make them understand that how important to clear the visual axis and make the child see. So the early referral is very important. So we have to make them understand. And this is just a training program wherein we focused and covered pediatric ophthalmologists and pediatricians, and also focused on residents who will be, later on practitioners, the both pediatric residents and ophthalmology residents, optometrists and primary healthcare staff. And in the educational institutions, we covered school teachers. We gave them awareness lectures, showed them pictures, and then what are the basic symptoms the child presents with, Anganwadi teachers, and this is all, what we're doing, just showing pictures of that. And the emphasis was to screen these children before they go to school, or even in the school every year, have a fixed program wherein all these children will be screened once a year. The training methodology, it is not going into the details. So it was done for the pediatric ophthalmologists. We had a program for 2 weeks. Even our own trained pediatric ophthalmologists, other general ophthalmologists were doing a little bit of pediatric ophthalmology, were brought back to the hospital for 2 weeks intense program where they had a logbook where they enter the data, wet lab training, video demonstration, hands-on. They got to do a couple of surgeries of pediatric cataract also. And the other NICU pediatricians and residents, they had lectures. Either some of them we did virtually, some of them in presence, and they all got a training kit with the torchlight, Snellen's chart. And we also went to the pediatrician's clinic where we set up the vision chart so that they can do a routine screening. Some of the busy clinics, in fact, our training optometrist was there on busy days. Like Monday is a busy day, he was there, screening at least 150 to 200 children on one day in the evenings. It did not affect our work also. So that was one thing we did. And again, the same thing was done for the optometrists and PHC staff and Anganwadi teachers. So we were giving them all the training credit, following up. And we also did post-training activity by following them and reviewing them with meetings. And the awareness program was also done in the community. When we go for outreach, or even in the, in the hospital, we're giving out a lot of, meetings, and then brochures to the patient, and increase the knowledge about childhood eye diseases with the focus on congenital cataract. So this is just to showcase the different kinds of programs we did. And most importantly, I forgot to share, this was done across all the the tertiary eye care centers of Aravind, from Madurai, Tirunelveli, Pondicherry, Salem, Coimbatore, Chennai. So we were able to cover a big area of children. And then one important thing was we held the help of the NGOs, the Shanti Ashram. We had the collector was here for the Vision Day, and then we released a poster, and also we came out with eye health card. So this was part of the project. And this is the methodology I already mentioned in detail to you. So identified defective children will be referred to any of the 7 centers referred. So it was not very difficult for the patient to travel long distances. And the referral follow-up also was done, and that's how we made it complete. So this is mapped all the places where the children will be, will have more footfalls to access healthcare. Then fixed vision chart, like already mentioned, especially in the schools and in the pediatric clinics. And then awareness posters in the waiting area of vision centers, in the NICUs, where there's a lot of footfalls of young parents. And of course, COVID did have some effect on the project, but then we did online training. And the opportunity was to depute our staff for the government vaccination, which in fact helped us to get the permission processes easily. So screening at the juvenile blind school, because sometimes we all know, like Sandra mentioned this, in the blind school, all of you would know better that in the blind school there are a lot of congenital cataracts not operated, because they're not aware that by just doing a simple surgery the vision can be regained. So this is to leave no one behind. So the impact of the project across the hospitals, we almost screened 3,61,213 children, and the schools around 3,85,000, and the vision centers screened about 1,49,000, in the pediatric clinics 1,31,000. So totally around 10,42,214 children were screened, and the classes were given to 1,20,233, and the cataract operated was 2,195 during this period across all the hospitals, and we've trained almost 5,410 healthcare providers and teachers. So this is the impact of the project. So totally the numbers we were supposed to train is 1,385, but we trained 5,410, and the teachers were 880 and almost 4,346. So which was definitely a good outcome of this project. So again, reach 2,000 people of different groups. So this will definitely give an awareness in the community, because you've trained so many people. So with this, I conclude that definitely this was a good project. I think though the numbers of cataract surgery, we're supposed to do 4,000, we did around 2,700. So we should always keep in mind that, this is the mission we have at Aravind for the Pediatric Ophthalmology Department. We always say that the children have right to sight, and we should all strive to give it with all our might, and preventing blindness, needless blindness, is what we do with care and kindness. Thank you.
Good afternoon. I thank the AIOS and the Managing Committee and Dr. Sandra for giving me this opportunity. I'll be just sharing our experience of screening 1 million school children. So this was by Level Fund, supported by Level Fund, and it was done at Tirunelveli and Pondicherry between 2010 and 13. So the main purpose of this project was to address the problem of visual impairment and blindness in school children among 0 to 17 years in the service area of Tirunelveli and Pondi, and to create awareness about the pediatric eye problems, as well as to develop a model for the service delivery. So we wanted to develop a strong referral system in the community, and these were the activities and targets which were fixed, and the expected outcomes. What we wanted to achieve was to strengthen our pediatric ophthalmology clinic at the base hospital, and to increase the patients coming to seeking healthcare. So the healthcare behavior also will improve, and increase the awareness level among the different stakeholders and the access. So we wanted to develop a scalable model, and this was the budget that was given, and this is the service area and the target population. Aravind Eye Hospital Tirunelveli, which will cover the 3 districts of Tirunelveli, Kanyakumari and Thuthukudi with a population of 59 lakhs, and Pondicherry, Kadalur and Viluppuram. So 2 extreme southernmost tip of India and the other on the northernmost tip of Tamil Nadu were covered. And these were the strategies: awareness creation, a knowledge aptitude study, and the development of the IEC materials, making seminars and conferences, and then screening in different age groups, starting from the newborn babies to the preschool children and the school students. And capacity building, of course, infrastructure, human resources, systems and processes to be kept in place, and finally the service delivery, hospital based or this thing. So this was the strategies, and we developed all the IEC materials and the awareness lectures for teachers, students and ICD staff. So the main thing is we got all the headmasters in. So for school screening, we call all the headmasters, and we gave an awareness talk to the headmasters, and we gave a free screening for them, and finished with a lunch session. So that brought everybody in. Like when we went in for the when the organizer went for the school screening date and all that, no, it made our things easy, job easy, because they had come here, they had seen this thing, we gave the lecture to them. It helped us build us confidence about it. So these were the accomplishments. Like we had screened 4,547 children, and 23,942 glasses were given, and 953 cataract surgeries were done, as you can see here. And 0 to 5 was also covered, around 1,15,460 0 to 5. So there was a learning in this also in ICDS, as Vijay Madam first initially was pointing out that you may not get lot of cases. Yes, we didn't get lot of refractive errors or something, but we got one or few cataracts we could pick up and few squints we could pick up, but not much of refractive errors in this age group. That is why they also have this, government also has this Kannoli Thittam from 6th standard to 10th standard. That's why they are also running, and we all know myopia starts by 9 to 10 years of age. So the other thing which we built on was the ROP screening. We really strengthened the preterm ROP screening, especially Pondicherry, which was not having a program existing at that time, and they strengthened it. And now at Tirunelveli, we are seeing 3,300 in the OPD and 4,173 through tele-ophthalmology, which is a huge number, and we are able to prevent so many children from going blind. And as we all know that it will really prevent lot of people going into lot of trouble, because it becomes very difficult to bring up a blind child. So these are some of our photos where we went to the ICDS centers. The thing is, we mapped the ICDS centers. So all of you know that ICDS has only around 15 children in the center. So we mapped the areas, and in a single day we will go to 8 to 10 centers, and so that we can cover more children. And the regular school teachers training program. I won't show the video because all of us, most of us know here. And we had exhibitions in the hospital, and we were celebrating the 25th year of Arvind Tirunelveli. So we had a huge exhibitions and lot of competitions, everything to create awareness for the children, for the parents and these children. So the school screening factors that helped us was because of the support given by the school management, the teachers, the district educational officers whom we had met, and the ICDS. We went and met them, the Sarva Shiksha Abhiyan and ICDS block officer. They were all very supportive, and we created a rapport also with the general physician, pediatrician, the general ophthalmologist, which helped in increasing the referral to the base hospital. And Sarva Shiksha Abhiyan of Pondicherry came forward to support the school screening and cataract surgery. And there was very good cooperation between the hospital, the project staff and the camp team. And daily almost 2 camps used to be really bet in for 2 school camps a day. So these were some of the challenges because of the government school screening program. In the first year, we couldn't get the permission to screen the children in Kanyakumari and Kadalur district. And so we utilized the private management schools and the primary schools and achieved the targets. And some schools were not willing to spare the teachers out to be trained in vision screening, fearing that it may affect the academic work. So what we did, we trained the field coordinators and some of our counselors to go and train them there itself, and we gave the charts there and came. And the poor compliance was there, and we are still trying to work on the improving the compliance. And the one thing that which helped was doing the training, screening by the class teachers training model, which I will show you now. So we learned that one of the other lessons we learned that was the respective class teacher is more effective than screening of all children by a few selected teachers. Previously, they used to send only the arts teacher or the sports teacher for the training for the training program. So only 4 teachers will come for 2,000 children. So instead of that, we trained the class teachers of all the classes, so that they just have to screen only 40 children, and it was a more effective screening, and there was more bonding between the class teacher and the children, and they made sure that follow-up also improved and the compliance also improved. So this another thing we learned was We helped us to understand the prevalence of refractive error in the 0 to 5 age group, and the community participation is very vital for any program, and it helped us to unearth our own capacity. From 30,000 we were able to screen up to 2 lakhs per year. So this was the project impact. We created awareness among the school staff, ICDS, and now they ask for the come and conduct the school camp in their school. So to that level we have grown up. And the increase in the pediatric outpatients, now we are seeing an average 160 to 170 patients per day at our hospital. So these were some of the publications which got published by Arvind Pondy, the all-class teachers model in epidemiology. And we had a publication about the non-compliance for wearing spectacles and what are the prevalence and determinants. These are some of the publications. We have to come up with more. Thank you. Thank you for a patient hearing.
Good morning, everyone. Myself, Dr. Anjali Khadia. I am going to present the screening children's under 6 years, our experience with photo screener. Thank you, Sandra Madam, to give the opportunity to present this instruction course. I have no financial interest in this presentation. Amblyopia is the most common cause, that is 2.5% of decreased vision in children, and older children are screened in the school, but there is no definite way of screening small children less than 6 years till now. So photo screening offer an alternative to traditional vision screening. It provides accuracy and advantage of speed, allowing the mass screening to detect the potential visual problem in these children. So here we assess the impact of screening performed by the non-ophthalmologist or our non-medical persons in the identification of embryogenic factors in young children, that is less than 6 years, using the pulse optic vision screener. So why this project? Problem faced in during the normal school screening is that the scarcity of the trained manpower to the screen the young children. Children are not cooperative during the screening, and a large number of children are not covered at one go. And 0 to 6 years, that is the critical age for the eye checkup, that usually left in school screening. So this vision screener pulse optic is their portable, battery operated, no formal training requirement for the screening, easy to screen our young children, and more children can be covered. So we did a total of 1,02,400 children less than 6 years underwent vision screening at ICDS centers and also preschools. Trained non-clinical persons perform the screening using the pulse optic portable vision screeners. The children with inconclusive or results were sent to the base hospital for the further evaluation by our pediatric ophthalmologist. So this vision screeners is designed to screen for the refractive error, anisocoria, and strabismus, but its strabismus indirectly detect, and in children starting at age of 6 months, both eyes are screened simultaneously. Screening performs from 1 meters, and screening takes only 8 seconds, 0.8 seconds, not even minute, and full range documentation options are available in the screen, and it is easy to use, portable and lightweight. Refraction, pupil size and cornea reflex are measured and compared to the age-based referral criteria automatically. A pass or refer screening results is displayed automatically, and refer comprised for those who failed the screening as well as those who results could not be concluded as a pass or refer. It can be connected to the office computer network or flash drive to import patient data or export screening results directly to the system. So this first one is the pass, and second and third one is the refer. These two last two one is referred to our base hospital to see by the pediatric ophthalmologist. So we screen 1,02,400 cases. Pass cases we got 77.84 cases, and refer are inconclusive children 22.15 percentage. Refer to turn off base hospitals and camp from it is 6,107, and total number of refractive error from that pulse optic we got that is 2,056 500, and the number of glasses provided 1789, and 71 cases queen, 18 cases children having cataract, 26 ptosis, corneal opacity 6, iris coloboma is 1, and retinal detachment 1, and number of surgery till done is 62 children. On it takes around 46 seconds, 90 seconds for the capturing, 50 seconds to type, and 12 seconds to save, only 46 seconds total. So girls are more cooperative than the boys. It takes 38.111 seconds compared to that is 54.48 seconds. And among the different age, first class students are more cooperative, then followed by second class, then upper kindergarten, then lower kindergarten. And on average, one machine screen 150 students a day, consuming 2 to 3 hours, and other times account for organizing children's and screening rooms, writing and the convey the child's information, writing the referral cards, and again re-screening of uncooperative or unconclusive children's. So this despite the high referral rate, that is 22.2%, and the poor follow-up rate, that is 27%, a large percentage of children who were presented, that is 30% were treated for the amblyogenic risk factors. It can be combined with the school screening. At screening young children is difficult even in the regular school camp. And children's visiting hospital with parents gives an opportunity to establish contact and create awareness. And last is the if cost efficiency is permit that school can have a machine to screen and refer the children, and it will be help in making the school screening a sustainable models. With the great success rate of this screening, we screen the vision scanner among the children with the learning disability. These children are very quite challenging and also time consuming for the ophthalmologists as well as just our staff. And we did students around 256 about age 2 to 17 years in 6 special schools, and first examined by the that vision scanner, followed by refraction, and then a complete examination by the ophthalmologist. So that sensitivity of the machines of this is the 91%, specificity is 52.14%, positive predictive 59.2, and the negative predictive value is 80.74%. This is the ocular morbidity we got from the special schools. Point is 21 and myopic is 31, that is more, and astigmatism and hypermetropy 19 and 1%. So here I am conclude that the plus-optic portable vision scanner is used by the non-ophthalmologist, offer an effective approach to detect the amblyogenic factors at an early age and refer on time. Thank you.
The first. Good morning, everyone. At the outset, I'd like to thank Sandra ma'am for the opportunity, and to conclude this session of AOS, the last talk here, the screening kids from 0 to 3 years and our experience with early intervention. So everyone, there's no need to stress the importance of early detection, because early detection and assessment for any visual impairment is crucial to help minimize the impact of VI and promote child's development. So we did this screening for children 0 to 3 years, and the total number of children screened in a year were 22,028. And uncorrected refractive errors were around 346 children. As expected, hypermetropia was the most common. Most of them did not need glasses, while myopic astigmatisms in 2 to 3 years. But refractive error was not a major concern because we didn't see much of it. Around 295 children with squint were identified and treated, around 11%. But the focus of today's talk was this visual impairment. Children with vision impairment was around 13.5%, around 360 children.
49% of those children had VI attributable to treatable or avoidable causes like cataract, ROP, refractive error, and strabismus. So this is why this study becomes important. And why did we think of this? Because of this data that came through Kansas University, where they did a child registry between 0 to 3 years, and they realized that the most important cause of vision impairment in children 0 to 3 years is CVI. So we thought we don't have something like that. Our most important was ROP and such, but then we were actually we found out, we disappointedly and unfortunately we found out that we had the same pattern, and 26% of children with vision impairment or children with low vision 0 to 3, the major cause was CVI only. So now it becomes important that these children get screened. So why is it so important? Because very early in life, if a child has a vision impairment, so the child is going to have developmental delay across all domains, leaving a mentally, emotionally, and a socially crippled child. That is why early intervention and active screening between 0 to 3 becomes important. So, and the assessment is very different, because 0 through 3, we would not do any visual assessment. All we would say is fixing and following, and that is not enough to say anything. So, always try and get an age appropriate visual acuity along with fields, contrast, and near vision. In an outreach setting, at least this much has to be done if you want to quantify a child for vision. And this is snapshot screening. This is something we'd like to do when we are in the outreach setting. One thing is fixation to a high-D face. So when a child has typically under 5 seconds of fixation, something is wrong. Please bring in them for a CVI screening. And 5 to 8 seconds, 8 seconds is optimal, it's normal. And when they have a prolonged screening, as a prolonged fixation as well, something might be wrong. So this is a snapshot screening that you can use in Anganwadis or schools or in NICUs. So why is this mirror test becoming so important now? If a child, when you get nothing in a child with CVI, if they have profound, severe CVI, you're not getting anything, not even fixing, following, show them to a mirror. If they can see themselves in the mirror, they can roughly see a human face at 2 feet. That is your distance and vision that you can estimate for the child. And a contrast of 5% in the high-D plate, hiding high-D of 5% equals the contrast of a human face. So in the outreach area, if you want to know the communicable distance from 30 centimeters, just keep coming back every 1 meter, 1.5 meter until the child is able to see the 5% contrast. At one point they will not see. So the last distance where the child is able to see this 5% contrast is the communicable distance that you can work with. And then for screening, again, this is something everybody knows, but why I've put here is, when you're going with an outreach team and you want to do a functional vision, you might not be able to take all your Lia paddle and puzzles and everything. So for screening, you can always use the Vikas app just to see if the child has any functional vision difficulty. So intervention, again, glasses, always glasses. 0 to 3, we have set protocols. There are AAO guidelines to say whom to give glasses. These children don't conform by those standards. Even if there is a small error, please correct. And accommodation, again, I can't stress enough, because they have accommodation difficulties. Most of them have hypo accommodation. If there is no accommodation, near vision suffers. They don't fix, so they have to be put on plus glasses. It is better to do a dynamic retinoscopy and give whatever accommodation they require instead of empirically putting them in +2 or +3. Also, a quick history that you can ask out in the outreach setting is that the child is not looking at faces, but the mother will tell, when I'm walking at a distance, the child is able to turn and see me. So if that is there, please look for accommodation specifically. So this is one case study. This one child who came to us at 3 months with ROP, not fixing and following, it was stage 5 ROP. All of us said that he's not going to see. And 1 year later, in April 2023, when he came, his stellar acuity was 2260 with a 10% contrast. Child is able to reach for objects and walks independently. Don't ask how this is happening. I don't know. This is the second child that's happening. So even when we think there is no visual potential at all, we still push for early intervention and vision therapy, because from not fixing, following to PL also means ambulatory vision. The child can independently walk and reach objects and negotiate, which means the child can be independent, and there is no cross disability when this early intervention starts. So always offer the child the benefit of early intervention. And this is another boy with, he is LCA, his sister is also LCA, she's in Braille. So this boy came to us at 5 years of age because his sister was getting trained in computers. He was supposed to join the blind school, but because COVID and blind schools were shut, he was just lingering around with us. So what happened was he, along with his sister, he just started learning NVDA, and in 1 year's time, he was proficient with basic keyboard use. So when the schools opened up, he didn't go to a blind school at all. He went to the government school with a laptop, and he goes to typical government school with laptops, and he's been giving exams in this also. Now Government of India has approved exams. Even CBSE class 12 and class 10 can give in online mode of examination. So this is very easy. They don't have to go to Braille and don't have to go around for a scribe. And the same orientation mobility, whenever a child has early visual impairment, the key thing is to make them get up and walk. Because a child can't see doesn't mean the child has to not walk also. So at 18 months of age, every child who is seeing or not seeing has to walk. So 18 months we start with a traditional walker. All children do very well with that. This is a post-retinoblastoma bilateral enucleation. So 2 to 5 years we put them onto strollers, which is very easy for them to tackle. And this is the same boy who saw with NVDA. Because he's 5 years and older, we gave him height-based canes, and this boy is pretty much independent now. So an online vision therapy, this started with COVID. We have pretty good experience with it. We don't have a lot of attrition. So we also schedule these visits so that it's easier, and they do it at home itself if they can't come back to us. And now something which has gained a lot of popularity with us is the buddy therapy or the sibling therapy, where you put the child's actual sibling itself during functional vision therapy, or you take another child with visual disability, something with a different visual disability or a different functional visual capacity, put them together and start training them. They help each other very well, and when you see, they pick up each other very well, and the therapy session goes much better than anticipated. Another point I would like to emphasize is this profound VI and cross disability, something called blindism. When children very early on in life just have visual impairment, they are just blind at birth and they are not rehabilitated early, eventually they get limited mobility, communication, conceptualization, their socialization suffers, and they end up as autistic by 8 or 9 years. They are actually not autistic. The problem is cross disability. So early intervention for these children, putting them to blind rehab becomes very important. What are the red flags for referral? Any child with insult to growing brain, any child who's been there in the NICU for long, preterms, all preemies, ROP, developmental delay, poor attention, learning disability. Anytime they say they don't behave properly in school, there's deviant behavior, please look up if they have issues. And multidisciplinary approach. We are all very familiar with the all under one umbrella, where the child is a center and everybody comes and does everything for them. In many centers, it is not at all practical because we don't have the space or we don't have the capacity to do it. But a better way of doing it is if every therapist is connected with the child in the center, meaning with vision therapy, when the vision therapy is happening, the PT and OT are connected through Zoom. So they know what exactly happens in vision therapy. And when physio is happening, the vision therapist, the speech and everybody is again connected over online. So the child can go wherever they are comfortable with. The PT or OT doesn't have to come to your place where they don't have their own setup and everything. All that is required is the child can do the child sessions where all other therapists are connected in one go and they know what is happening, so they can simultaneously do it. We've been trying this and it works comfortably well, and all therapists are happy because they have their own comfort zone to work with. And outreach, these children are not going to come to us if you're going to sit waiting for them, because most of the time they only don't know what the problem is and they'll eventually present late. So always look for areas where you can do outreach. One problem is 0 to 3, you can't go knocking on doors all the time. So pediatricians, OGIans especially, because OGIans many a times have a chance of finding it. They have preeclampsia, complicated pregnancy, they know they're going to pull in for a early preterm session. They will know that at least they have to tell the parents. So OGIans, neonatologists, NICUs, everywhere we can actually screen. Vision screening or grading acuity can be done as early as 32 weeks in preemies, and it's been documented. So it is not that in preterm you cannot see vision, you can still do it in the NICU. Anganwadis are a good area. This is another thing we've tried right now is online camps with pediatricians. So this is us connecting with a pediatrician in Virudunagar who has a few cases every Friday. He brings in patients. So online only he tells what the problem is so that we can fix up an appointment with them online. We can also talk to the parents, tell them what to expect, why is this important. So we have a follow-up, kind of the loop is complete. So this we are doing every year. The DIC of the concerned district hospital is also connected so that we can get in this early intervention with active referral. So finally, to conclude, active referral and networking is very important if you're going to screen these children. And thank you for the opportunity. And thank you everyone for being in this IC at this last moment. On behalf of Sandra ma'am, I'll thank everyone.
And do you do the proper real assessment and rule out organic causes? So is it possible? Because many times that's the problem which I face is like when you go to remote areas, very difficult for them to come to us. SSA Sarva Shiksha Abhiyan. Okay. So this is basically for the government schools, isn't it? Government schools only have the Sarva Shiksha Abhiyan. No? It's not for the block. Even but the private schools are not covered in that. I think. They'll do it. And just one more thing. Sometimes when you're screening 3 years, na 0 to 3 years. So sometimes you have children with delayed visual maturation. And so then you're saying it's okay even if you start them early. It's fine. They would have just had. So no need to isolate and separate them. Start them anyway. Yeah. Fine. Thank you. I know. But ma'am, actually we are called by a lot of private organizations like which are running these. So, but we need some infrastructure support, from the government also because it's difficult. Thank you.